Good afternoon, ladies and gentlemen. Thank you for the invitation to this webinar. It is an honor and a pleasure to present amongst such remarkable specialists. As a pediatrician and pediatric pulmonologist, I will talk about what is unique in lung ultrasound in children. Sonographers dealing with adult patients are equipped with standardized protocols for emergency medicine, among others the Blue Protocol and the EFAST, and with recommendations for point-of-care lung ultrasound in intensive care medicine and in internal medicine. The recommendations deal with ultrasound application in numerous disease entities and respiratory symptoms, from cough, dyspnea, acute lung injury, through pneumonia, interstitial diseases, neoplasia, pulmonary edema, embolism, congestion, atelectasis, to abnormalities of the pleura and the diaphragm. This remarkable paper, prepared by an international group of experts, includes a few recommendations regarding the use of lung ultrasound in neonates and in older children. They concern respiratory distress syndrome and transient tachypnea of the newborn, pneumonia, and pleural effusion. There are also available free publications concerning guidelines and recommendations for lung ultrasound in neonatology. They apply to typical problems of this age as RDS, TTN, meconium aspiration syndrome, pulmonary hemorrhage. They also include SAFE protocol, which aims to exclude the life-threatening conditions, and instructions for LAS-guided procedures. They also concern congenital malformations of respiratory tract and diseases which prolong into later childhood, as bronchopulmonary dysplasia and other diseases which occur also later. The body of evidence is usually smaller in pediatrics than in adult medicine, but in case of lung ultrasound, it is also smaller than in neonatology. Why are children excellent candidates for lung ultrasound? They have thinner chest wall and smaller lung volumes, and the younger the child, the more cartilage elements and the weaker calcification of bone elements. However, as pediatric sonographers, we also deal with some difficulties. Our patients have physiologically higher respiratory rate, and they won't stay still. Firstly, because they are much more active than adults, and secondly, because they are afraid of medical procedures and the staff. But we can deal with uncooperative child by warming the gel, examining infants while feeding, toddlers when seated on the caretaker's lap, and using other distraction techniques in older children. Children are excellent candidates for lung ultrasound, but is the relationship mutual? Compared to classical imaging techniques, lung ultrasound is much better accessible, unburdened with ionizing radiation, short time procedure of good sensitivity and specificity, easily repetitive, with no need for sedation in younger children. The training time is relatively short, costs are low. The main limitation of the method is the fact that some lung areas are inaccessible for ultrasounds, either because they are covered with bones, as retroscapular area, or with healthy, properly aerated lung parenchyma, as perihilar areas. Also, we cannot visualize the whole lung at one time, as it is possible with CT or MRI. As in other imaging techniques, we should follow the ALARA rule, which for lung ultrasound in children would be to use as low mechanical index as reasonably achievable. we still lack a thorough description of normal lung ultrasound in children and its changes with development. We draw the knowledge from several publications where healthy children were examined as control groups and from our own clinical experience. In younger children, meaning neonates and younger infants, we often visualize more numerous vertical artifacts, namely eye lines and, according to some authors, also Z lines. These shorter vertical artifacts do not have assigned clear clinical significance. However, when using linear transducer only, they can be mistaken with B lines. The latter, when numerous, do have clinical significance. During the evaluation of the same area with a convex probe, it is possible to distinguish which of these vertical artifacts are actually B lines. Facing the lack of pediatric recommendations, a panel of experienced sonographers from different Polish tertiary centers prepared an evidence-based consensus on the application of lung ultrasound in pediatric population. The initial idea was to prepare recommendations for a wider spectrum of childhood diseases, but a sufficient body of evidence was found only for pneumonia and bronchiolitis. Based on the consensus, I can state that the interpretation of lung ultrasound should always be performed within a clinical context. The entire available lung surface should be examined, including not only transthoracic, but also transabdominal approach when possible, as it enables the assessment of the lung bases. A linear transducer is the most commonly used. However, it is worth to reach for microconvex or convex transducer in case of excessive adipose tissue, transabdominal approach, and a need for differentiation of vertical artifacts. Lung ultrasound findings in pneumonia in children are the same as in adults. We can visualize small subpleural consolidations, larger consolidations with bronchograms within. In this case, static bronchogram within atelectasis. Color Doppler enables assessment of the vessels and differentiation between vessels and fluid bronchogram. We can also visualize interstitial syndrome, pleural line irregularities, and pleural effusion. What is also typical for younger children is the presence of the thymus. When performing the examination of the anterior parts of the lungs, it is relatively easy to omit consolidation adjacent to the thymus. Color Doppler can help with distinguishing, but because of the patient's small size, cardiac pulse can disturb the assessment. Pneumonia is one of the most common medical problems in pediatrics worldwide. That is why the body of evidence in this disease entity is the biggest. Based on the consensus, I can state that compared to chest X-ray, diagnostic value of lung ultrasound is equal or greater. Color Doppler improves it. If the results are normal, the probability of diagnosing pneumonia is low. Consolidation is the most common finding. Compared to chest X-ray, lung ultrasound sensitivity in detecting consolidations is greater. Lung ultrasound cannot determine the etiology, but it is useful in monitoring the course of the disease, its treatment, and in diagnosing complications. Pneumonia is diagnosed more often in children than in adults, but the ultrasound findings are the same regardless of age. It has already been proven that ultrasound is the method of choice for pleural fluid assessment, as it enables not only detection of small volume fluids, but also the assessment of the characteristics of the fluid, not achievable with other methods. On this slide, you can see one of the complications of bacterial pneumonia. which is lung abscess. The abscess formation can be initially visualized with color Doppler as a lack of vascular pattern and can be proven using contrast-enhanced ultrasound, non-enhanced area. The figures are taken from the WFUMB review paper, which is currently ahead to print. Bronchiolitis affects infants and toddlers beneath 2 years of age. This is per se a clinical diagnosis, and therefore there is no need for routine imaging evaluation. However, in some patients, imaging modalities may prove helpful. Lung ultrasound findings consistent with bronchiolitis are consolidations, usually small, focal multiple B-lines, compact B-lines, areas of wide lung, pleural line abnormalities, minimal pleural effusion. These findings are spread bilaterally, and we can see affected and spared areas. Compared to chest X-ray, lung ultrasound specificity and sensitivity are equal or greater in bronchiolitis. The additional value of lung ultrasound is the fact that it is useful in assessing the severity of the disease. There is a good correlation between sonographic and clinical findings. Basing on the bronchiolitis ultrasound score, we can identify children in increased risk of needing supplementary oxygen and/or respiratory support, and we can predict the risk of hospital admission. Lung ultrasound is also useful in monitoring the disease. There are few publications available concerning lung ultrasound in COVID-19 in children. The findings are the same as in adults, namely vertical artifacts, thickened pleural line, and consolidations. Like other imaging techniques, lung ultrasound cannot determine the etiologic factor. However, regarding the pathophysiology and the whole clinical picture, lung ultrasound findings can be suggestive of specific groups of pathogens. The first difference lies in the distribution of changes. In typical bacterial pneumonia, they are more limited to the single area, while in viral infections, they are more diffuse. In COVID-19, the changes predominantly occur posteriorly and laterally. Consolidations of bacterial etiology are usually larger, and thus we can see bronchograms inside of them. Single B-lines and pleural line irregularities in bacterial pneumonia usually occur near consolidations, while in viral infections they are more numerous, scattered, and confluent, and often compose interstitial syndrome or areas of wide lung. In viral infections, pleural line is often thickened and pleural effusion minimal, while in bacterial pneumonia, pleural effusion can be extensive and can evolve into empyema. Congenital malformations of the respiratory tract are rare diseases and are extremely rarely seen in adults. There is an example of extralobar pulmonary sequestration. On the left figure, you can see non-aerated area of consolidation, which is separated from the healthy lung with pleural line, showed with white arrows. On the right figure, you can see systemic supplementary artery. Congenital pulmonary airway malformation is visualized as a multiloculated cystic lesion filled with hypoechoic fluid. It is bordered by hypoinflated lung parenchyma. The lung sliding was present in the area. This is a case of aspergillosis in a bronchogenic cyst diagnosed in a 2-month-old boy. You can see a cyst filled with hypoechoic fluid with non-homogeneous mass inside. The quality of ultrasound images is comparable to these of CT scans. Thanks to the lung ultrasound properties, the child could be closely monitored during the antifungal treatment before and after the lobectomy, without exposing it neither to ionizing radiation nor to anesthesia. I could present you this rare case thanks to the courtesy of the Pediatric Pulmonology and Allergy Department of the Medical University of Warsaw, with Professor Kulos as the head, Dr. Sanocki, attending physician, and Dr. Komorowska-Piotrowska, sonographer. When Nenek invented the stethoscope, there were strong opposite voices doubting its value. History repeats itself with lung ultrasound. Roberto Copetti wrote that lung ultrasound is the stethoscope of the new millennium. I dare to say definitely not. It is much more. Since I have started the adventure with lung ultrasound, I never look at such a sky the same way again. Thank you for your attention. I will be happy to answer your questions.